Welcome. My name is Shalini Desai, and I am one of the medical officers within the Immunization, Vaccines, and Biologics group at WHO. We will be reviewing Module 5, Identification of Target Populations. By the end of this module, you should be able to describe the role of the NITAG for COVID-19 vaccine review, how target populations are defined, and a process for ensuring equity in vaccine access. The goal of the global allocation of COVID-19 vaccines through COVAX is to protect public health and minimize impact by reducing COVID-19 mortality. In order to do this, in Phase 1 of vaccine allocation, participating countries will receive doses in tranches to cover 3% of their population. This amount was agreed to in order to allow enough vaccine to cover health workers in most countries. More doses in tranches to cover an additional 17% of participating country populations will then be delivered. In Phase 2, participating countries will receive additional doses to cover more than 20% of their population. The timing of Phase 2 will depend on country need, vulnerability, and COVID-19 threat. Furthermore, a buffer of vaccine will be set aside for humanitarian deployment. In order to define and identify the target populations for allocated vaccines, the National Immunization Technical Advisory Group composition may need to be modified to meet COVID-19 vaccination needs. Then, it would be necessary to identify regional and national data sources to inform decision-making. Countries will also need to establish a process for staged decision-making as data becomes available. As countries begin their deliberations, there are a few specifics related to COVID-19 vaccines that are different than our usual vaccines. There are over 300 vaccine candidates that are being tested in various stages of vaccine development. The process to create these vaccines has been accelerated. As a result, there is limited data on efficacy and safety. We anticipate there will be a high demand for vaccines since COVID-19 has been a high public health priority, but we anticipate a limited supply. The COVAX facility expects 2 billion doses of vaccine by the end of 2021. As a result of the uniqueness of our COVID-19 situation, there are consequences for the structure and function of NITAGs. In terms of structure, additional expertise may need to be added to include specialists in adult vaccination, respiratory disease, an ethicist, and potentially also others such as social scientists may need to be added. Additional support from ex officios such as health worker associations, medical or nursing associations, occupational health colleagues, social care or other agencies who may oversee care of older individuals, and other relevant national bodies. Additionally, further strengthening of the Secretariat may be needed. As far as function, NITAGs will need to ensure that they are coordinated with other national bodies that have responsibilities for COVID-19. The NITAG will need to increase the frequency of its meetings, potentially weekly for the working group, and every other month for the entire NITAG. They'll also need to experiment with virtual meetings either through Zoom, WebEx, Teams, or Google Meetup, and use platforms such as Google Docs and alternative to allow fast-track changes and to be able to work simultaneously on documents. The process that NITAGs undertake will need to be more agile and transparent. Evidence will evolve over time with changes in epidemiology and new evidence emerging over time. Transparency can be strengthened by making the minutes of NITAG deliberations available, publishing interim recommendations, clearly indicating the process undertaken and further refinements that are expected over time, as well as posting declaration of interests of your committee members. The approach used will need to be phased since we envision phased introduction of the COVID-19 vaccine until a healthier marketplace develops. This will have consequences on the types of recommendations that can be made. Therefore, NITAG should make explicit the data limitations and where assumptions have been made. Explicitly state the objectives of the vaccine program. Issue interim recommendations to identify priority groups for vaccination, and refine the interim recommendations as new evidence emerges. The data needed to make these decisions includes data on burden of disease, factors contributing to severe COVID-19, the epidemiology, as well as acceptability of COVID-19 vaccines. These data can be national if available, or global. Information on the vaccine landscape, timelines for vaccine availability and supply will also be needed. Additional considerations may include transmission dynamics, natural immunity, and duration of protection, and vaccine characteristics and demand. Some of this will be known, some will not be known, and over time, what is known and unknown will change. As a result, NITAGs will need to stay abreast of the literature and how emerging evidence may alter their recommendations. This slide is a schematic diagram of the NITAG process over time. As would be done in a usual NITAG process, the objective of the vaccination program should be used to define the policy question. This question will determine what data need to be sought and what assumptions will need to be made. A smaller working group of the NITAG can synthesize the data and then bring that data back to the NITAG for review and deliberation. The NITAG as a group can then determine the priority groups for COVID within their country setting. Interim recommendations can be made so that preparatory work can begin. Further work by the NITAG can occur once specific vaccine-related data and availability is confirmed. During this phase, it is anticipated that new data will emerge, and through an iterative process, the NITAG can provide advice on allocated vaccine target populations, the schedule, vaccine acceptance, etc. Why make an interim recommendation? This process allows for preparation of allocation and implementation of vaccine strategies. It also allows the NITAG to understand the gaps in knowledge so that further data can be collected to be used in the next iterations of policy development. Interim recommendations increase transparency in the process and thereby build public trust and also support communication strategies to ensure strong vaccine uptake and will contribute to vaccine confidence. The following three areas are the basis for prioritization: epidemiological scenarios, which could be defined as community transmission, sporadic cases or clusters, or no cases but importation risk. Public health objectives of the vaccine program include examples such as reduction in morbidity and mortality, maintaining essential services, a reduction in disease transmission, and/or reciprocity. And finally, vaccine supply scenarios could be defined as very limited, stage 1, where 1 to 10% of a population can be offered vaccine, limited, stage 2, where 11 to 20% of the population can be offered vaccine, and moderate, stage 3, where 21 to 50% of the population can be offered vaccine. Global materials that are available for thinking through the epidemiologic scenarios include the WHO SAGE roadmap for prioritizing use of COVID-19 vaccine in the context of limited supply. While this is a busy slide, this slide provides the details contained within the roadmap when there is community transmission of COVID-19. And based on the availability of vaccine, NITAGs will need to consider country-specific data to determine which stage they are in and who should be vaccinated. Similar to the last slide, this one is specific to sporadic cases or clusters of cases of COVID-19. This slide shows considerations when there are no cases of COVID-19 within a country, but importation risk continues. Within countries, it will be necessary to estimate the size of different target groups. Here, we have the definition of health workers and possible data sources. There may be additional sources at country level. We also have older people, and a definition of that will be based on NITAG deliberations and data sources for estimating that target population. Two further groups that may need to be estimated include people with underlying health conditions and other target groups. National equity of vaccine should also be considered. All individuals at increased risk of COVID-19 should have equal access to vaccine. This would include ethnic groups that are at high risk of infection or severe disease, socially disadvantaged groups who are not able to maintain physical distancing measures or who have limited access to health care. Gender-related issues may need to be addressed, and finally, low-income, migrant workers, migrants, refugees, and displaced populations also need to be considered. The key messages from this module include decision-making should be based on the WHO SAGE values framework complemented by the WHO SAGE prioritization roadmap. Data from national regional sources should guide country-level decision-making. Wide stakeholder consultation with additional representation on the NITAG will ensure country-appropriate decision-making. Accurate estimates of target groups will help in planning vaccine rollout, and equitable access to vaccine should be a guiding principle. In summary, for all countries participating in the COVAX facility, there will be a global allocation of COVID-19 vaccines. In country, it will be important to define and identify target priority populations and to estimate their size. Equity should be a guiding principle in distribution. Here are WHO SAGE resources that are available online. Here are additional resources available for NITAGs. Thank you.